Welcome to Evidence-Informed Policy, Advancing Health Equity for All Children. This is the last of the three-part Child Health Equity System-Focused Learning Series. I'll begin this morning by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin and Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to Indigenous people from all over Turtle Island. And Children's Healthcare Canada is committed to working towards forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health outcomes from coast to coast to coast. It's my pleasure now to introduce Dr. Krista Jangaard, who will be providing opening remarks to start off our day together. Krista is the President and CEO of the IWK Health Centre in Nova Scotia and incoming Chair for Children's Healthcare Canada Board of Directors. Krista, I'm now passing the virtual mic to you.
Thank you very much, Paula. Welcome, everyone, and good afternoon. Well, it's afternoon here. Good afternoon or good morning, depending on where you are in this wonderful country we call ours. It's great to have many of you online with us for the last, as Paula said, the last of our three events, focusing on child health equity and in a system-focused learning series. Please take a moment if you want to and feel free to put your information in our chat box. It's always a good way to introduce yourselves to each other and to see who's in this virtual room with us, as we can't see you all of the time when moving forward. I am very pleased to be here today and was very pleased to be one of the sponsors for this series with our colleagues at Children's Healthcare Canada and at One Child, Every Child. It's really wonderful to be here to represent the many people at IWK Health for whom this is a passion and a strategic priority as we move forward in thinking about children's health in an equitable and fair way across our country. I'd like to add my local land acknowledgement. I am coming to you from Halifax in Chibouctouc, in the ancestral and unceded territory of the Mi'kmaq people. They have been here for generations and have provided stewardship and care for the land and the resources that we have in Nova Scotia, New Brunswick, Newfoundland, and parts of PEI. I'd like to say thank you for sharing those resources with us as we work together under treaties of peace and friendship, and think about how we focus ourselves on working together for health and well-being of our children and families together. I'd also like to acknowledge that as settlers, many people have come to our great city here and to our province and have added vibrancy. And for all of our settlers and for our First Nations have been faced at times with prejudice and with racism and with unequal access to things that we need to think about together. One such group is our African Nova Scotian community, who have been in Nova Scotia for more than 400 years and have contributed greatly despite facing racism, which they still do face today. So as we start to think about equitable care and access to care, let's think about equitable communities and equitable relationships as we work through reconciliation and as we work with our communities. So with that being said, this is, as was mentioned already, the part 3 in the Child Health Equity Learning System. We have had 2 previous sessions. Earlier this month, we gathered for the first event, which was called Delivering Equity in All Child Healthcare Services. And in that session, we explored the critical intersection of child health and equity in a variety of settings. We examined challenges, shared best practices, and envisioned a future where every child has access to quality health care. From culturally competent care to community engagement initiatives, each session left us with actionable steps to drive positive change in our healthcare system. Later in the month, on March the 21st, we gathered for the session called Inclusive Child Health Research for Equitable Outcomes. And this event integrated and investigated the impact of non-inclusive research on equity-deserving communities that highlighted the practical aspects of inclusive research and community engagement, and examine the intersectionality of childhood disability and racial identity and ethnicity in Canada. So today, our last session is going to focus on evidence-informed policy to advance health equity for all children. And I have the lovely privilege of introducing the opening session speakers for today. So I'm delighted to introduce our keynote speakers, Dr. Shazeen Suleman and Dr. Cassia Johnson. Dr. Suleman is a clinical associate professor at Stanford University in the Department of Pediatrics. But prior to joining Stanford, she was an assistant professor at the University of Toronto, where she developed the Compass Clinic, which I think we're going to hear a little bit more about, which provides trauma-informed care for newcomer and Indigenous children with special healthcare needs. She currently serves as the co-lead of policy implementation with the Anti-Racism Taskforce on the Canadian Pediatric Society. We will also hear a pre-recorded piece from Dr. Cassia Johnson. And Dr. Johnson is the originator and physician co-lead for the Canadian Pediatric Society Anti-Racism Initiative. She is also an associate professor at McMaster, the senior director of EDI at Hamilton Health Sciences, the in this big long list, the co-director of diversity and inclusion at the undergraduate medical program at McMaster, and the director of anti-racism inclusion in the Department of Pediatrics at McMaster. That's a whole lot of things focused on a very important issue that we're going to talk about. Clinically, Dr. Johnson works as a developmental pediatrician and has a passion for providing care for a large population of neurodiverse children and youth, many of whom experience racism and oppression in the healthcare and educational institutions. Dr. Suleman and Johnson bring you the Canadian Pediatric Society's Anti-Racism Initiative from Prologue to Chapter 1. Over to you, Shazeen.
Thank you so much. I'm going to now share my presentation with you all, and I apologize. I am a little under the weather, so I hope you can all still hear me quite well. So thank you again for having me here, and I am hoping that I can do this work justice, recognizing much of this is built on the leadership and expertise of Dr. Johnson. I'm joining you from Ohlone territory, and I really like this reframing of what we call the national anthem in so-called Canada, that it is our home on native land. My family came to what is now called Canada as refugees. And I have always been struck by a conversation that I had with an elder who asked me that if my parents and my grandparents had known how the Canadian government had treated Indigenous people, would they have considered Canada a place of refuge? And that has really struck with me because it highlights to me how interconnected our struggles are, and how, as I work to support people who are displaced from their ancestral homelands, it means I need to be in solidarity with the very people who have been displaced from the land that I am standing on today. I also recognize that right now there are many people who are being displaced from their ancestral lands around the world. There are many people who are suffering. And for all of you who have connections to places around the world, we see you and we hear you. And if there's at any point during this conversation that you need to take care of yourself, please do that. Today, I'm hoping I'll be able to tell you a little bit about the Anti-Racism Initiative that the Canadian Pediatric Society has been working towards, and along with Dr. Johnson, tell you how it came about, along with a process that we've used to look at how we're reviewing organizational policies and tools. We hope that this might provide some inspiration and direction for those of you in similar organizations, and we'd like to share some opportunities for us at the CPS. So neither Dr. Johnson and I have no conflicts to declare, but we both carry biases. Despite being people of color, we also sit in positions of power and privilege in society as physicians, as people who are educated, as people with permanent status in so-called Canada. We're the lived experience of intersectionality, where race, gender, socioeconomic status, and other factors intersect. And so we're committed today to show you how this casts a lens on the information we're presenting today. We want to hear your comments and concerns about any ideas or words that you'll be hearing today. We recognize that we're not immune to harming others. And so regardless of what our intent is, if there has been any harm that has come from the language that we use today, we welcome hearing that and learning how we can be better. And so I'm going to turn it over to Dr. Johnson to tell you about how this all started.
Hi, my name is Dr. Cassia Johnson, and I'm one of the physician co-leads for the Canadian Pediatrics Anti-Racism Initiative. Today I wanted to tell you about how our initiative came about. I have long been doing anti-racism work and approached the CPS in 2018 and 2019 to start doing some anti-racism work. At that time, it was felt that this concept was much too large for CPS to take on. Like most of the world, we watched in horror as George Floyd was murdered on May 25, 2020, below the knee of a Minneapolis police officer. Following this, there was urgency at the CPS to start our anti-racism journey. The CPS staff were very supportive of this initiative, starting with our getting our house in order. We started by committing to our actions and language being intentional and thoughtful. For example, anti-racism is not hyphenated, following the concepts as presented by Ibrahim X. Kendi, that to be anti-racist is an active action that is different from being not racist, which is often a passive one. We also thought about the word initiative rather than using task force and other terms that do not follow the iterative process of our work or speak of the aggression that actually we witnessed to start this work. We started by re-examining the organization's actions and activities. We pulled together grant funds to be able to pay a consultant to develop our anti-racism policy that would guide all of our activities. We engaged with T. Garnett with Providence International EDI Consulting that helped us develop a policy that spanned the organization from provider engagement to membership activities. You'll hear more about that in a moment. Once the policy was created and connected to the board of directors, it allowed us to move forward in creating a steering committee that has national representation, specialty representation, and is developing a sense of racial and ethnic language representation from across our membership. From here, we developed co-lead models to start our work grounded in anti-colonial ways of leading, and we put a call out to the broader membership. A huge number showed interest, and in fact, we had over 100 members wanting to get involved. After a number of meetings, it became apparent that the three areas of focus would be policy review, medical education, and advocacy, as these are concepts and areas that CPS already works in. And each of these areas, we had to look at how to develop the systems and tools to help members and staff beyond the steering committee and working groups to do the anti-racism work that is truly needed to become an anti-racist organization. And again, as I said before, we started by looking at ourselves and our organizations first.
I'm so glad you were able to hear from Dr. Johnson directly, because
hi, my name is Dr. Cassia Johnson.
It's incredible to watch her speak in person. And so this is how we first started. But
hi, my name is Dr. Cassia.
We're now going to tell you a little bit about the actual policy that was developed. And again, I'm going to turn it over to Dr. Johnson to tell you about this.
Hi again. I wanted to tell you about the actual CPS anti-racism policy, and my colleague, Dr. Shazeen Suleman, will tell you more about the specific policy work in a moment. But the anti-racism policy itself includes objectives and a framework, a look at leadership through governance, development, development, diversification, decision-making, accountability, and transparency. And it also has areas that cover membership, our in-office staff, education, communication, research, and relationship with our suppliers, and the important health issues that are beyond the actual scope of the policy. You can find this policy on the CPS website, but I thought it would be important to highlight, as I said before, T. Garnett from Providence Consulting that helped us write this, whose picture you can see on the screen beside me, but also that the policy supports the vision that racism needs to be identified and eradicated from our organizations. The communities that we serve and represent see themselves valued and reflected within the CPS work, membership, and leadership. That the vision is also that the national, ethnic, racial, cultural, religious, and linguistic diversity of Canada is reflected in the conception and delivery of child and youth healthcare, and that racism is recognized as a social determinant of health, and that our clinicians adopt strategies to mitigate its effects. The purpose of the policy is to shape and enhance the processes, practices, structures that promote an environment free of discrimination, prejudice, and bias, where all individuals are treated with respect and dignity. The purpose of the policy is also to identify and eliminate barriers that have prevented members or staff who identify as BIPOC from participating fully in the CPS community, including leadership. And the policy is to ensure that the principles of equity, diversity, and inclusion are used to shape CPS policies, procedures, relationships, and advocacy efforts. Because as CPS, we have a responsibility to be accountable to this policy and commit to upholding the commitments and the expectations of our members. We ensure that members who identify as BIPOC are not exploited or overburdened by the practices and procedures that are developed to implement this policy, and that we model anti-racism practices to our members and partners as we identify, adopt, and develop tools and training to ensure that members, leadership, working groups, and staff can implement the policy. We recognize also that the policy, our language, as this learning evolves, changes, and so we have a commitment to reviewing this policy every couple of years. We've used this policy as a guiding light to look to and about our activities and actions as we consider what activities we are engaging in and the steps that we are taking with each new engagement. Now, Dr. Shazeen Suleman will be able to lead you through our policy part of the tool.
So I wanted to, before I begin in talking about the work that we've been doing, I did want to share how incredible it has been to be part of an institution that even has an anti-racism policy. I remember not too long ago, when I was a resident, I had seen a posting for International Women's Day about women leaders in pediatrics in Canada. And every single one of the women that were featured were white. And I remember feeling, even as a trainee at that time, that does that mean I could never be a leader in pediatrics in Canada? And when I reached out to the leadership at the time, they said, well, that's just who our leaders are. So that wasn't that long ago, because I didn't finish my training a very long time ago. But even that feels like in this day and age, if that were to be done in 2024, I think the response would be very different. So personally, it's been a very affirming journey for me to be part of this work. So when we say policies, what do we even mean? What we mean is that many times we look at the work that we are doing externally facing, which is, as clinicians, can be our clinical work or our medical education. But we also need to look at the very rules and structures we use to govern ourselves, our programs and our procedures, because they can perpetuate discrimination even inadvertently. What that does is they communicate what our values are, what our culture is, and what our expected behavior or conduct is. So if we do want to become an anti-racist and decolonial institution, it does mean examining these very processes, which at the time could feel very meta and hard to do. And policies can be racist or anti-racist. If a policy or a guideline or a bylaw has contributed to unequal representation, unequal access to power and decision-making, or it doesn't provide equitable, not equal, opportunities to participation, whether it's intentional or not, then that is perpetuating racism through this intersectional lens. And then conversely, an anti-racist policy, in our opinion, strives to ensure that that does not occur. And safeguards have been actually made to encourage full participation and full sharing of power. In order to help us do this, we thought it would be best if we actually developed a tool to help us review our existing policies, bylaws, and guidelines. This was not meant to be exhaustive. It's not meant to be a one-step solution, and nor is it meant to be an only solution, but it was meant to provide an opportunity for reflection and critique. And we would hope today that this provides hope and affirmation for others who want to embark on this journey. And again, we share this with humility, recognizing we still have a lot of work to do. The way we developed our tool is we went through the literature, we went through published literature, we went through gray literature. We also had conversations within our group with many people with lived experiences to see if there were any existing tools. And then internally, we compared the tools. We said, like, which are the, using a matrix, does it actually address the questions and the content that's appropriate for us? And then adapted this to fit within our CPS, our Canadian Pediatric Society needs. There are 4 main steps to this tool. And again, you'll see that it is not meant to be a tool that provides a checklist or an answer, but really provides an opportunity for structured reflection. And there are 4 main steps. The first is reflecting on one's positionality, which I will walk us through, and hopefully will not be that unfamiliar to many people here. Making sure that people have spent time with our anti-racism policy, and then take time to read the policy, the procedure, the guideline that you intend to review, and identify specific next steps to address gaps in anti-racist practice. As we said, we tried to do this work through an intersectional lens. And it's very important that whenever we embark on this work, we know that where we are coming from. You need to understand where your own axis of power, privilege, and oppression are. And that intersection is shifting based on and relational based on where you are. For example, in a room where I am the provider, or if I'm teaching students, I may have some axis of power. But then the minute I go to the airport, I can tell you that I feel like I have no power because for some reason I'm always screened for security. This work needs to be approached with humility, with openness, with self-compassion and kindness. This is not meant to be a judgmental or demoralizing exercise, but recognize that we all have shifting positions of power and privilege. And it's something that we have to commit to in an ongoing and ongoing way, with an openness to changing our thoughts. After you've done this work and after you've familiarized yourself with the anti-racism policy, which I'll be happy to share in the chat, we have a series of questions that we ask users to first go through. The first is, does this policy or guideline acknowledge the systemic, historical, or current axes of oppression or discrimination? So for example, is there an explicit statement acknowledging how individuals who belong to communities who have been historically or currently marginalized or harmed by existing systems of oppression? For example, is there acknowledgement of how individuals who are racialized had been excluded from the organization? And if not, why has that not been acknowledged? And the second question is one that can be a little bit more difficult, but we ask people to look and say, have some groups been unintentionally harmed while other groups have unintentionally benefited? And we recognize that we recognize that in the majority of this work, it's unintentional and it's not meant to leave people feeling guilty or judged. So For example, if there is a grant application that's focused on health equity, but doesn't actually center the people with lived experiences, or doesn't provide compensation for people with lived experiences, then that may be an example of how groups have been unintentionally harmed while striving to do good. The third question we ask is that, do all aspects of this policy or guideline aim to explicitly address historical and current axes of oppression? So for example, does the policy actively aim to increase representation with individuals who have been historically or currently oppressed? Does the policy aim to explicitly increase education or raise consciousness? And does the policy identify or assert responsibility for how it may have contributed to current or historical axes of oppression? And this might be extremely subtle. For example, if meetings have always happened at 7 p.m. at night, that may be inadvertently contributing to people who are child caring not be able to participate. And is that then leading to decreased representation? Or have meetings always been held during Ramadan, which it is right now, and Ramadan Kareem to all who are celebrating? But does that again inadvertently perpetuate decreased inclusion for people who have been observing that or may not be able to participate in the same way? And these are just small examples that I'm sharing. And at the last part of this tool, we ask people to do some reflection about, why does it even matter that we're doing this? Why is it important to do this if we're actually striving to achieve equity as a group? We hope that in applying the tool that there can be some specific actions that can come out, recognizing that this tool is not meant to be exhaustive. We're not saying we're going to solve we're not going to be able to become a completely anti-racist organization with one application of this tool. But for example, we recognize maybe a review of policy of conference programming. There's never been an explicit statement that speakers should be diverse through an intersectional lens. And maybe that's important to add. Or maybe when we're looking at bylaws for a particular committee, even though there's a commitment to represent people with from different aspects of what is now called Canada, there's no commitment to represent individuals with diverse lived experiences through an intersectional lens. And again, these are examples that we think are tangible and actionable for other organizations to do. So this is just some early work that we hope we can share with you. Again, like I said, coming with humility, not saying that we have all the answers. But in addition to this internal facing work, our team, as Dr. Johnson highlighted, we have a medical education and an advocacy team. We're working on similar tools to help us with that external facing work that we do. We wanted to share some gratitude to the members of the Policy Implementation Working Group. These are the other members who have contributed to this work. And I'm now happy to stop and turn it over to you for any questions or further conversation. And I can stop sharing the screen now.
So this is my chance to remind everyone, if you have questions, type them away. Did you, as you developed the tool and sort of field tested it on various policies, did anything surprise you in what you came up with?
That is such a great question. So, I think what surprised me is how insidious it has been to have structurally racist policies that I don't think we even appreciated how we were contributing to racism. And again, the example that I shared about the conference speakers was one of the most visible ones that stood out to me, right? That I don't think anyone is intentionally trying to make speakers not diverse or not have lived experiences, but without an explicit commitment to doing that, you end up with, like I shared, the feeling that I had when I was a resident, seeing all the women leaders in pediatrics. Without that explicit statement, you can end up with showcasing a side of what is now called Canada that is not representative of who is around us. And I think for me personally, because I was able to also relate to what it feels like to not see yourself represented, it helped me understand the greater importance of this. But I think I was struck by how many opportunities there are for us to move the needle towards anti-racist work. And it's not as earth-shattering as I thought it was going to have to be. It's really small nudges that we can start to do to move the needle along.
And at a health systems level, because some of this racism is almost cooked into the system. It was developed on a sort of colonial or other basis that not purposely, but it disenfranchised, continues to disenfranchise a lot of people. At a health policy higher than organizational level, how would you suggest we all go about this other than reflect on our own selves and our own organization?
I was a little bit distracted reading Jane's question, but I'm wondering if you might be able to repeat your question. Sorry.
Oh, challenging now. At a health systems level, what can or should we do beyond reflecting individually and changing ourselves and reviewing our organizational policies, but at a broader system level, are there particular learnings from what you've done that can help us make the right changes?
I mean, I think the first step as systems is we have to acknowledge that systemic racism exists, right? And take away any and work to take away any individual guilt or shame. By virtue of existing in the systems that we're in, we are all complicit, whether we are racialized or not. And again, looking through that intersectional lens, I take responsibility for being complicit, and I can also see how my ancestors and others have been harmed by those policies. And I know that sounds very trite, but I think even that simple act of acknowledgement is very difficult to do.
Yeah.
The second piece is really looking for, with an open mind and open heart, how has a policy inadvertently biased individuals? So for example, if you work in a health system, and I work primarily caring for immigrant and refugee families. If the signage at the very front says, ask for your OHIP card, but a family who may be new to Canada doesn't have it, are you inadvertently perpetuating worse harm by, rather than saying, please show us any documentation that you have, or just come and introduce yourself and support it, we'll support you with your name.
Right.
I think these are small examples of how you can or for example, having a late policy that's very fixed, that if you're 15 minutes late, we're going to charge you, which I recognize I recognize where that comes from, but does that really understand where everyone's lived experiences are coming from? And without including people who are affected by those policies in that decision, then are you also perpetuating more harm? Which I actually would really love to get to Jane's question.
So I can read it out if you like. What is the process for determining which policy you reviewed first or next? And did you partner with people implementing or impacted by the policy? Did you undertake training to better understand their positionality so they could become active partners?
So Jane, this is a great question. And again, I want to remind you that these were policies that were internal to CPS. So these were not any policies that were external facing. And what I mean by that were they were our own Canadian Pediatric Society internal bylaws, or they were a section or a committee within our Canadian Pediatric Society's bylaws, or the Canadian Pediatric Society conference speaker bylaws. We have still been piloting this. So this is where we are not saying we're finished. As a member of the CPS, I offered my own committees that I was a part of as the ones to pilot test. And we worked very hard to make sure that on the committee that was developing this tool, we had diverse representation of lived experiences by race, ethnicity, language, geography, as much as we could within our own organization. We have recognized that many people need training, and we are working on providing training again, as myself, training my peers for how to use this tool, how to even do critical self-reflection, and how to identify actions that can be taken, because for many people, this is still new work.
Yeah. Yeah. There's been several questions that have come in, and I see Krista has her hand up. So I'm going to have Krista speak, and while I organize those other questions. Go ahead, Krista.
Well, thank you so much, Shazeen, particularly since you're not feeling well. I really appreciate you sticking with us and presenting today. And I don't know if I have my hat on. As Paula mentioned, I'm the incoming chair for Children's Healthcare Canada. So thinking of a national organization that really is, has a focus on how we think equitably about children and youth and their families. Or whether I have my hat on as the CEO of a children's hospital, where the enormity of the policy work, both for the policies that we have in place for care and for our patients, but also all of the policies that we have around our own HR and our own staff. So very early on our journey, I think this is a journey that's going to take us a while. I guess it's a little bit of an extension of the last question is, when we're starting to think of that, I think what I heard you say was find a group that is a champion to start with when you're looking at policies, and then think about how you have to, who you have to involve. If I was to talk about the staff policies, do you have any tips for how we ensure, although I don't find myself very frightening or very intimidating, I carry the authority that comes with my office, I have positional power, I have privileged power by my job, by the fact that I'm a white, fairly well-to-do woman. How do I encourage the psychological safety in our organization to have the people who we need to be involved?
That's a great question. And I want to answer that in two parts. And I think the first part is that individuals need to know that they're not being tokenized, and that real sustainable action is going to come from their recommendations. And absolutely, thank you, Amy, that there is a real difference between safety and comfort. And safety, I think, is important to prioritize those who have experienced historical and marginal, historical oppression and current oppression. Their safety is tantamount. And again, I'm not going to say that I am an expert in this work. This is just sharing from the experiences that we've had in the Canadian Pediatric Society. I don't think I would have even embarked on this work had I not seen other colleagues who I trusted, like Dr. Johnson, being at the helm of it. If I had not seen someone like Dr. Johnson leading it, I think I would have been a lot more reluctant that this work was really meaningful. And the second thing was that I have also seen a real commitment from our executive director and our leadership that they are the ones that have invested time, invested money, invested, they've stated explicitly that we're going to use this tool to change our bylaws. Like, this is happening. So that, I've been part of other efforts in the past where I felt that it was just akin to thoughts and prayers. Like, yes, we have this organization. Yes, we have this committee. We're going to do this work and it's not going to go anywhere. And that is really disheartening. That does not have, inspire people who have lived experiences of being marginalized to say, I know that this organization is committed to being different. Because what that means is sharing power and sharing responsibility, right? So really sometimes it's like swallowing a piece of humble pie and saying, wow, I'm going to be told things that I didn't realize I was doing or we were doing as an organization, and I'm going to be willing to really listen. I don't know if that really answered your question, but I'm just trying to share why this felt different for me than other work in the past.
It actually does in part, and it is the struggle between being one of those people who is a leader, but comes at it with I am not who I am because I deserve to be who I am. I'm just who I am. I have learned, looking at Amy's notes I have learned how to be uncomfortable and live with being uncomfortable. And as a physician, we're not often easy to say we don't know stuff, but in this area, there's a whole lot I don't know. And so how to promote that being uncomfortable, being able to say, I don't know, being the champion and having it, being dedicated to having those conditions be okay for people to actually be safe, I think is one of the roles as leaders we need to think about as an ally. When we have, I am never going to have the lived experience, but I can be an ally. So thank you. Yes, you answered me.
Thank you, Krista and Shazeen. Cindy has asked a question. She says, I know I should know this, but tell me why anti-racism isn't hyphenated. She mentioned she looked on her corporate website and the word is still hyphenated and she'd like to learn more.
So I would direct, thank you. And so I also had to learn this, and it's from the work of the scholar Ibram Kendi, where again, as Dr. Johnson said, that by hyphenating it, we separate it from, by hyphenating it, it also implies that it is the same as being non-racist, which is hyphenated, but it is an active process all on its own. It's an active intent. It is not the same as just being non-racist or not perpetuating racism. It is an active undoing of anything that perpetuates racism. And so I think that's why Dr. Kendi doesn't hyphenate it, to help convey the message that it in itself is a distinct piece of work. I hope that answered your question.
Yeah, it's beyond being against it conceptually. Yeah, it's the act of doing something intentionally. Another question, wondering what your thoughts are on what seems to be, in the US at least, pushback on EDI and whether that may slow progress in Canada. Interesting.
That's a great question, as I'm located in the US now at a US institution. And as a Canadian in the US, it's a unique perspective. I think, and again, this is my own opinion that is not representative of my institution, but while we in Canada are certainly not immune to what happens in the US, I also think we, again, by taking an active stance, by taking active steps to undo work, we can also be a leader for the US of how we can do things differently. Because anti-racism, while it's related to equity, diversity, and inclusion efforts, is in itself a distinct effort by actively undoing. So diversity on its own, having a diverse pool of staff members or people with lived power can be an important step towards anti-racism, but people with diverse experiences can perpetuate racist policies unless we have actually looked at them with a critical lens. So they're distinct concepts, but related, and I really hope that we in Canada can lead our US colleagues forward in understanding that.
That's wonderful. Alicia asks, have you found any solutions that promote attendance and inclusion as much as possible, given of various groups? People might be working and can't attend during the day, or parents can't attend at night, and so on and so forth. What what are the success factors in doing that well?
One, I think it's so dependent on what you're doing and who you're working with, that's why I think having people with lived experiences who have not been able to do that at the table, or even the concept of, sitting at a table can in itself be an exclusive concept. So my other work is as a researcher, and I do community-based participatory research. And I really draw on those principles similarly when we're doing this work, because what it says is that if interventions or any programs that we're creating to support communities have to be led and initiated by the community. And just like if I want to build a house for myself and I hire a contractor or an architect, the contractor and the architect are tools that are helping me create my vision. So I similarly see that I am a tool for the community that we are trying to support. And so to answer your question, I don't want to I don't think there's one size that fits all solutions, but one approach that I think really helps you find a useful solution for your organization or your community is having the input of the people who are affected. In a very small way, we've found that hybrid meetings can be useful if people, for example, can't attend, finding what time works. When I do community advisory boards, we have people participate through one-on-one meetings that we share back. We go to their house, we have Zoom meetings, we have meetings with food. It takes time, it takes money, and the process is slower, but that's what it means to be able to do it well. I don't think I'm giving you very good answers, but I hope it's a little helpful.
Oh, I thought that was a great answer. I want to thank you and Dr. Johnson again for a great presentation. There are a number of additional questions that I may forward to you and, for your answers in time, and we can share them back with folks.